Dr. Sana, for that kind introduction, and thank you, Sridhar, for the very kind invitation. I think this is the latest talk I've ever given. So let me begin. We'll talk about neonatal seizures. There's some nice pictures here. Normally I would invite you to come, to London or to Al-Ain, but in these COVID times, these pictures will have to do. So I have no disclosures apart from the fact that I don't have all the answers, if that's what you're looking for. So in the next 25 minutes, what I want to do is try to answer three discrete questions. Why are neonatal seizures important? And I'm going to talk about just term babies. Preterm babies are a completely different kettle of fish. So I'm going to talk about term babies. So why are seizures important in term babies? Number two, how can we diagnose seizures? And number three, how should we manage seizures? So those are the three questions I'll try to talk about. First of all, some definitions. So there are, if you like, three groups of seizures. So they're what people call clinical only seizures. So this is a sudden abnormal clinical change that doesn't have an EEG correlate. Then there are EEG only seizures or electrographic seizures, which have a clear seizure on EEG, but don't have any outwardly visible clinical signs. And then there are the third group, electroclinical seizures, where you have simultaneous clinical signs with EEG correlate. And another term people use is status epilepticus, which there are many different definitions, but one is, for example, seizures which last for more than 50% of 1 hour on EEG. So those are some simple basic definitions. So let's try and address the first question. Why are neonatal seizures important? Well, firstly, they're the commonest neurological emergency in the NICU. And I'm pretty sure everyone listening will have at some point in their career dealt with a seizure in a baby or an infant. The second reason they're important is they exacerbate perinatal brain injury. Now, previously, we thought that actually brain injury was what caused the seizures, and that the poor outcome in these babies was related to the brain injury, and seizures were like an innocent bystander. Well, not innocent, but a bystander. So we know that brain injury causes disability and it causes epilepsy. But what about the role of seizures? Well, it's becoming clear that seizures have an independent effect on brain injury. So they exacerbate brain injury, for example, in the context of hypoxic ischemic encephalopathy. So seizures through a number of actions, including hypoxia, secondary energy failure, increasing brain lactate, utilization of brain glucose, loss of autoregulation, and changes in intracranial pressure, as well as the excitotoxic cascade that's associated with brain injury. So there are a number of different mechanisms that we've identified mainly through animal studies that show that seizures independently worsen brain injury. So I'll just talk about a few key studies which show actually that that's the same is true in humans and human babies, as well as what we found in the animal studies. So this is a study, sorry, my arrow seemed to have moved, but I will try to show you where we are. So this is a study by Stephen Miller, who's a fantastic clinical scientist in this area and has produced some seminal work, including this study. This is MR spectroscopy, magnetic resonance spectroscopy, which can show different metabolites in the newborn brain. And what it's doing is comparing babies with hypoxic ischemic encephalopathy on this side, who didn't have seizures, and those who did. And they're matched, so they have the same severity of brain injury, so they have the same severity of HIE, but one group had no seizures, the other group had seizures. And you can see that this marker, NAA, is a marker of neuronal integrity. So it means the neurons here are much healthier compared to here. And the lactate peak here, you can see, is very high, which is again another marker of cerebral metabolism and hypoxia ischemia. And you can see the lactate peak is barely noticeable here. So there is evidence here that there is something going on in the brains of these babies who have seizures, which is different to the babies who don't have seizures, even though they have the same brain injury. What about neurodevelopmental outcome? So this is comparing the outcome, and again, in babies with HIE. So those babies who had normal outcome here, the blue box, and those babies who had abnormal outcomes, so cerebral palsy or epilepsy in the red box. And how they're being compared is the maximum seizure burden. So that means how many minutes in 1 hour they had seizures for on EEG. And you can see that the group that had normal outcome had far fewer seizures in that maximum 1 hour compared to the group who ended up with cerebral palsy. And then when you correct that for brain injury, so you match the babies for brain injury and you do a logistic regression, you can see that that still holds true, is that seizures are again an independent marker of poor neurodevelopmental outcome, so more disabled children. And actually the effect is really quite marked. So for every 1 minute of increase in seizures, in the maximum seizure burden, the odds of an abnormal outcome increase by 16%. So that's a massive increase. So seizures are not good for neurodevelopmental outcome. And then this is a study by Hannah Glass, who again is a fantastic clinician scientist in San Francisco. She looked with her colleagues at IQ using WIPSI, which is a standardized neurodevelopmental assessment tool. Between 2 and 4 years, she looked at children, and this is their full scale IQ. Again, this is corrected for the brain injury on MRI, and you can see that there's a dose-dependent effect. So as seizures increase, the IQ, the full-scale IQ, becomes lower and lower. So again, it's a strong argument for the independent effect of seizures. I think I've convinced you, hopefully, that seizures are not a good thing for the injured brain. So now we know we want to do something about it. The challenge is, how can we diagnose seizures? So diagnosis is clearly a challenge. What looks like a seizure might not be a seizure. And conversely, what doesn't look like a seizure may actually turn out to be a seizure. So there are sort of 3 reasons I've listed here why diagnosis is a challenge. The first is there are many different classification systems, which basically means people can't agree what seizures are. The second thing is that newborns are different from children and adults in that their seizure patterns can be very subtle, they can be very brief, just lasting a few seconds, and they have a very varied semiology. So they can be things that you well know, things like sucking, boxing, cycling, as well as the tonic-clonic seizures that are seen in older children and adults. And the third thing that's difficult in newborns is this phenomenon of electroclinical uncoupling, which is very common, which means that what's happening clinically is not necessarily related to what's happening in the brain, and that's to do with obviously the wiring in the newborn brain. So diagnostically it's a challenge. A different classification system. So there is no agreed classification system. I've just put 3 of the commonly used ones here. So lots of people know Joseph Volpe. He's a really eminent neonatal neurologist. So he described in his textbook and in his publications a classification system. I won't go into the details, but just to show you that nobody can agree, essentially. Then, for example, another commonly used classification system is the International League Against Epilepsy classification system, and their task force on neonatal seizures drew up this very nice document. And then there's another system used by the American Clinical Neurophysiology Society. So you can see, you know, that nobody can really agree. It's a difficult thing to diagnose. And the third thing I mentioned is that there are many different types of neonatal seizure, and I've put here just so that you can see the incidence of some of them. So clonic seizures maybe account for 1/4, tonic seizures again another 1/4, myoclonic seizures maybe another 1/4, and many subtle types of seizures which can easily be confused with normal movements. So diagnosis is a real challenge. This is some pictographic descriptions of some studies. You can look at the studies in more detail, but I think these pictures give you a good idea of what I'm talking about. So when you look at all documented clinical seizures, so this is a large cohort of babies where the nurse documented a seizure, and you can see that when you look at the EEG, only about 30% of them had seizures. So basically, the vast majority who were thought to have clinical seizures didn't actually have electrographic seizures. So clinical diagnosis is clearly difficult. And the second thing is this electroclinical uncoupling, which is very common. So when you look at all babies with seizures who have been diagnosed with seizures on AEG, about 60% of them, so more than half, will have subclinical seizures. So that means they had seizures on the EEG, but you didn't see anything with the baby clinically. Looking at that another way, again, in all babies who had seizures on the EEG, 20% of them only had EEG seizures. So they didn't have any signs of seizures that the clinician or the nurse would see. And then again, when you look at all electrographic seizures, so this is adding up all the seizures in all the babies from this particular study, you can see the vast majority of seizures don't have any clinical signs. So only 10% of the seizures on EEG actually had clinical seizures that were identified by the caregiver. So clearly there's some difficulty with diagnosis clinically. The gold standard is continuous EEG, and this is a document, a position document by the American Clinical Neurophysiology Society, which clearly states that the gold standard for diagnosing seizures is continuous EEG. Now, clearly, there's some difficulties with that. That might be the gold standard, but I wonder how many of us have access to continuous EEG. Video EEG in our NICUs or in our pediatric units. Not only that, who is there who can interpret these EEGs? So you can have wonderful recordings, 72 hours of EEG recording, but who is going to interpret it? And also, who is going to interpret it at the time you need the information? So in the middle of the night, rather than looking at the EEG 3 days later, which maybe is not so useful clinically. So this feeds into some studies which have basically shown the lack of that kind of tool available in ICUs. So you can see in all babies with electrographic seizures, 20% of them never had any treatment. So in those, so these 20% of babies had seizures but didn't ever get any treatment. And these studies are from big tertiary centres where they have experienced clinicians and experienced nurses. So that's under treatment. What about over treatment? So again, in all babies who didn't have seizures, so these are babies who had EEG where people were worried about seizures, 10% of them had anticonvulsants when they never had an electrographic seizure. So this is over treatment. So under treatment and over treatment. And then delayed treatment. So you can see clearly in all those babies who had electrographic seizures, most of them had their treatment initiated more than an hour after their first electrographic seizure. So under treatment, over treatment, and delayed treatment. And all this because we don't have this gold standard of 24-hour video EEG. So what do most neonatologists use is the AEG, or amplitude integrated EEG, which is like a compressed and cut down trace. So it's incredibly useful because it can be analysed straight away. It's like a point of care test. It's a cot-side test. And this is a publication, again, you don't need to look at the details, but the gist of it is basically that it's incredibly variable at picking up seizures. So it's a fantastic tool, but it's highly dependent on the user's experience. and the familiarity with it. It can also miss short seizures because it's a compressed trace, and focal seizures can be missed because it's different from a full EEG with multiple electrodes. It's only got a few electrodes, usually 2 channels or a single channel, so it can miss focal seizures, and it tends to pick up much better generalized seizures which affect the entire brain. And you can over-predict seizures with AEG. Because of the presence of artifacts, like movement artifact, for example, is a big one. So, for example, artifact can blight up to 60% of records. So it's a wonderful tool because it's easily accessible, but it can depend on the user's experience. It can miss seizures, and it can over-diagnose seizures. So ultimately, we're left with in a difficult situation. Just a quick note on what the future might hold is automated seizure detection. And this is a study from Imperial that I co-wrote, looking at an automated seizure detection tool. So this means it's an algorithm inbuilt into the AEG, which will automatically trigger identification of seizures. But this has still not yet reached the bedside. So we're still left with the dilemma of how to diagnose seizures. The gold standard is continuous video EEG. Clearly, we don't have that. The next best thing we do have is amplitude integrated EEG, but we're still looking for something better. So the third question I asked at the beginning was, how do we manage seizures? So the first thing, resuscitation. I don't need to tell you any of you this. This is clearly the most important thing. The second thing which we've just talked about is that you need to confirm these are seizures and not something else. And it seems like AEG is our best bet at the moment. The next thing is to look for an underlying cause and treat that underlying cause. And then the fourth thing is to think about anti-seizure drugs, anticonvulsants. And I'll talk about sort of 3 things to think about, which is looking at treatment goals, avoiding overtreatment, and recognizing status epilepticus. So the first thing is to look for an underlying cause. The neonatal seizures are usually symptomatic. So again, this is different from seizures in children and adults, where epilepsy is much more common. In the newborns, they will often have a cause, and this is a nice figure, not mine, I can't take credit for this, but you can see the majority of seizures in the newborn are caused by hypoxic ischemic encephalopathy. And then you have other things like brain malformations, intracranial hemorrhage, genetic issues, metabolic issues, and infections like meningitis, for example. In this part of these studies are done in the US and the UK. This kind of data comes from. And you may well know that in this part of the world, this subset here of the genetic neurometabolic conditions is much larger than in other parts of the world. So it's always worth thinking about these kind of things. So we should really evaluate at the same time as doing all the resuscitation. Think about evaluating with a clear history, looking at clinical signs, baseline blood tests, which should include some kind of metabolic screen, imaging with a head ultrasound if you can get it quickly. EEG, as I've said, ideally a full EEG, but AEG we can usually get quite quickly. MRI will come later, particularly in the context of hypoxic ischemic encephalopathy. And as I've just mentioned, if there are any clues to a genetic cause, for example, dysmorphism in the baby, or abnormal metabolic tests, or a positive family history, it's worth thinking about genetic testing, although there's a cost implication of this. So moving on then to treatment goals. So when we're talking about anticonvulsants, what are we trying to achieve? So the 3 things I think we're trying to achieve is long-term to reduce the brain injury, or short-term to reduce brain injury, to reduce the ongoing risk of epilepsy, and to reduce long-term disability. So with that in mind, when should we treat seizures? So how long? This is the question everybody asks. And again, there's not really a consensus. So I've again put 3 examples that you could use. So the WHO suggest seizures more than 3 minutes, either clinical or EEG, should be treated. just to bear in mind that the WHO guidance is designed to be used throughout the world, so particularly in the underdeveloped world where they might not have some of the things that we have in the UAE, for example. The International Neonatal Consortium suggests treating seizures more than 30 seconds within 1 hour epoch on the EEG. And if you look at expert consensus practice throughout the literature, people will treat anything between 10 seconds and 2 or 3 minutes per hour on the EEG. And my practice is basically somewhere along here. And the distinction between these is that we're looking at electrographic seizures and we're not looking at just the clinical seizures. And then moving along on treatment goals, what are we trying to achieve? Oh, there are many things that we might try to achieve. The first thing we try to achieve is complete resolution of seizures on EEG. We can achieve that a lot of the time, but obviously sometimes we can't manage that. So we might then look at things like reducing clinical seizures, which are causing problems with breathing, problems with hemodynamic status, if we can't control all the electrographic seizures. Then we might think about reducing the seizure burden. So that means maybe throughout the day you want to reduce the amount of time the baby is seizing, and so then promote cognitive development. Or you might think about reducing the specific type of seizures. For example, you might think about reducing generalized tonic-clonic seizures, which are clearly more dangerous for the patient and have implications for neurodevelopmental outcome, and be happier with focal seizures, tolerate focal seizures. So there are things about treatment goals. We want to reduce long-term disability. We need to think about the time that we allow seizures to go on for before we treat, and we need to think about what the long-term treatment goals might be. So then I'll quickly rattle through anti-seizure drugs. These are the common ones that I think probably most people have some experience with, that I'll talk about. And there are a bunch of other agents which I've put here. I won't talk about these things because really they're still very much experimental in the neonatal period. Lots of people are using them, but I think really they should be used in the context of a research study. But just to give you an idea, these are two seizure protocols. This is one from where I work in Imperial in London, and this is one from where I work in Canad Hospital. And you can see they're actually different and have different drugs at different stages. And the point I want to make is not the details, but again, nobody can agree on a seizure protocol because of the lack of evidence for using different drugs. So rather than try to look for the absolute best evidence and spend hours through literature, what I would suggest is that everyone have a standardized seizure protocol in their own unit or in their own hospital. And actually what's much more important than choosing drug A versus drug B is to try and treat seizures very quickly and adequately. I'll move through some of the drugs. Phenobarbital, everybody knows about this drug. This is Alfred Hauptmann. He described this many years ago. So the benefit of this drug is that we're very familiar with it as pediatricians and neonatologists. We can use it intravenously, we can use it enterally, we can use it for maintenance treatment. It has first order kinetics, so we can predict the dose. The problems with it is not very efficacious, so it only terminates seizures at about, let's say, 40–50% of the time, and it can cause respiratory depression. But that's still our, our first line, and what we have the best evidence for efficacy. Probably the second most commonly used drug is phenytoin, and again, it has a similar seizure termination efficacy, but it has much more in the way of side effects, and it has second order pharmacokinetics, so that it's much harder to dose and avoid toxic effects, which can include cardiotoxic effects, which if you think about in the context of a baby, for example, with hypoxic ischemic encephalopathy, might not necessarily be your first choice. Benzodiazepines, again, another really common agent. Midazolam is a very useful thing because you can use it as an infusion and you can titrate the response. Lorazepam is very useful for intermittent dosing. People tend to use this as a second or third line because the data on efficacy is not as good as phenobarbital. And again, the side effect similar with phenobarbital is that there's issues with sedation and respiratory depression. Levetiracetam or Keppra is a newer agent which is becoming increasingly popular. There's a couple of, or more than a couple, but two big studies looking at its efficacy, which pretty much show that it's not as efficacious, or it doesn't appear to be as efficacious as phenobarbital. So it certainly shouldn't replace phenobarbital as the first line agent, but it's a useful second or third line agent because it has much less sedation and seems to have a much better side effect profile. And there's some suggestion of some neuroprotective effects. So that's definitely something to think about, and definitely the adult literature and the pediatric literature really supports the use of levetiracetam. And then lidocaine, it's just worth mentioning, lidocaine is very popular in Europe. It doesn't seem to be used in the States very much. The efficacy is probably about 20% in retrospective studies. But people in Europe really like it. I really like it. The problems with it, it's really an acute treatment. It's IV only, and it can also have some effect on hemodynamics. So I'll wrap up there. As I said at the beginning, I've tried to look at three questions. Why are seizures important? Well, they're harmful, and they have an independent effect on brain injury. So they exacerbate underlying brain injury, particularly in the context of hypoxic ischemic encephalopathy. The second question is, how do we diagnose seizures? Well, clinical examination is not reliable. The gold standard is continuous video EEG, but probably the best we have is amplitude integrated EEG. So that's what I would recommend. And the third thing is, how can we manage neonatal seizures? So the drugs we have are imperfect. They're not particularly effective. But what is important is to use a standardized protocol so that we can start these treatments early, because the earlier you start any anticonvulsant, the more likely you are to terminate the seizure. So I hope that's brought some light to this really tricky topic, and I'm happy to sort of answer questions in the Q&A afterwards. Thank you very much.
Thank you, Dr. Hoque, for this detailed presentation. As you mentioned, you do have like 4 questions, I think, in the Q&A section. I'll hand over now to the chairman to close the day, Dr. Swekar.
Thank you, Dr. Sana, and thank you, Nick. I mean, excellent talk as usual, and I mean, it would be great if you can answer the questions in the box itself, as we are a bit late. So coming to the close of this excellent conference, I mean, there is no doubt that the quality of the scientific program has been remarkable all through. The testimony to that is the fact that right from start to finish on all 3 days, we have had close to 2,000 participants online, which probably indicates that more than 3,000 people have been moving in and out. So hats off to the organizing team for that. So first, thanks to all the participants for your active participation. Obviously, the webinar format gives us the flexibility that even though the speakers took a little longer in some of the talks, we were able to allow them to answer the questions after the session concluded. So the people who ask the question get the answer, and at the same time, we are able to keep track. We are not that much behind schedule, despite the speakers not compromising on the length of their talk. So again, sincere thanks to all the speakers and the chairpersons as well for being patient and having been accommodative for the schedule changes as well, because the neonatal session was supposed to be a Friday day session in person, and then we decided due to the situation that it would be merged into the stream. As I mentioned yesterday, merging into the stream was a useful thing for all of us because we have the advantage of attending so many interesting pediatric topics, especially the great speakers from Pittsburgh as well. All of us benefited by attending those topics, and it it was a useful session to be merged. And the sponsors have been very kind and supportive, and I would like to thank our titanium sponsors, UPMC, Children's Hospital Pittsburgh, Gen Farm, and Novartis, as well as our gold sponsors, Bayer, GSK, and Novo Nordisk. We hope to get the similar level of support for our future events as well. The team from Marifa, as you must have noticed, is extremely professional. They are very well organized, and they have been a great support all through. I mean, Soha has been a great help in putting together the excellent program, getting in touch with all the speakers, arranging the change in sessions as needed, and suggesting modifications. So one cheeky suggestion was to remove my lecture from the talk. So I've sacrificed my topic, which was hypoglycemia. And I invite you to watch that on my YouTube channel, which I posted yesterday. Just search my name on YouTube. And Dr. Dova leading the team from the front, Jamila, who has been perfect doing the groundwork in the real show, and Jeevan for all the technical support. And I have not named everyone, obviously, but so many people working hard behind the ground to make this happen. And finally, we have the raffle. And let's see who has the win for today. I mean, there were 2 winners yesterday, and you would be contacted among those announced yesterday who were replied in the chat box. And today as well, we expect you to answer in the chat box. So I'm going to pick one special number, which is 1234. So Jamila is 1234. Julie Seon. Is Julie Seon in the audience currently? Let's check in the question section. There is another one, Alia Imad. Dr. Alia, is your number 1234?
I think she's not here, Dr. Sridhar.
Okay, then we will move to 1298. Nasma Karavi. Okay, Nasma Karavi is there, so congratulations. Yeah, congratulations, Dr. Nasma. And let's see what you win. Our organizing team will get in touch with you, and you will be getting the post by mail. So, I mean, the prize by mail rather. So, I think we will send a thank you email, and the feedback link will be sent to you. We request you to feedback and also make suggestions for future topics or any future speakers. Obviously, the webinar format has its faults. At the same time, it has so many plus points, because in a real conference on the final day, in the last session, we have 10 or 15 people attending sometimes. So it's frustrating for the speakers to be having a small audience. But now, thankfully, you are sitting in your living room, you have put your kids to bed, you have finished your dinner, and now you're still watching. So we didn't miss much. And as I said, the timekeeping has been easier as well. So there are positives, and I think in future, it might be a good idea to do in-person conferences merged with the online, because it enables people from all around the world to join us. So with this, I think I'll say thank you to everyone for joining us, and good night. And hopefully we'll have a great session very soon in the next conference that we organize as well. So if you have any feedback, do send, and then certificates will be sent to you. We might be sending you either the copy of the presentations where there is permission, or a link to the videos. I'll also try to post these videos individually on my YouTube channel. So good night, and we will finish with the video from the organizing the sponsor.